Good afternoon, everyone. Thank you for joining. It is 1:59. We're just going to wait about a minute or two and give everyone time to join our webinar. Today, we have a fantastic discussion planned for everyone today, and I do hope that you learn a lot and that you're as excited about this as I am. We'll get started in a minute or two. If this is your first time joining us at EHI, I want to say welcome. And if you've joined us before, I'm going to say welcome back. It's always good to see familiar faces and have old friends join us in a number of our educational series. It's a gorgeous day here in Maryland. We were just talking about the weather, actually, how it's just been a really pretty day. And hopefully it stays that way. We've had a number of cold days these past couple of days. It's been cold and hot and cold and hot, but hopefully the weather stays on. Yes, I will turn on caption. We have a request here. I will do that. Hi, everybody. It's 2 o'clock. We're just going to wait a few more seconds, maybe about 30 seconds or so, before we go ahead and get started. Great conversation today, talking about public health modernization and some of the lessons that have been learned during COVID. Really excited to kick this series off today. I think this is a series that's long overdue. As we all know, COVID, the past, I think we're going to say year 3. Now we're in year 3 of this pandemic, and there's been so much to learn and so much to talk about. And there's still a lot more for us to, for us to discuss. I think that this is ongoing learning for each of us. And so this webinar today, I think, is very, very timely with everything that we've seen, starting from the beginning of the pandemic, then going through to vaccine rollout, to seeing a number of policy changes that have happened, and seeing how technology has responded to support the public health system and support health systems in general with their response and resilience and eventual recovery. There really has been a number of things that have taken place over the past couple of years. And so we're really going to just talk about that, some of these lessons. Where are we? Where are we going? And how did we get here? I think that's the question on everybody's mind, is how did we get here? And how do we move away from there? So it's 2:01. I'll just go ahead and go through some quick slides before I introduce the speakers. I'll introduce myself first. My name is Dixon. I am the Director of Programs and Strategy here at Executives for Health Innovation, EHI. We're now a big EHI. We went through a great name change about a month or two ago. Our mission hasn't changed, although our name has, and we're still very proud to bring together a number of stakeholders to talk about healthcare and bring together a number of thought leaders, and to also function as a thought partner. Next slide, please. We are an organization. We have 4 major focus areas this year. Number 1, modernizing public health, which is exactly what today's webinar is about. Also health equity, very important topic. It's become very much top of mind with some of the things we've seen in the past year, SDOH and health equity. And then also virtual care. As you know, due to COVID, a number of providers, we shifted to virtual care, and that in itself brings up a number of conversations as well, making sure that the people that need to access healthcare can, and that the providers that need to provide the care are still able to with virtual care. And last but not least, privacy and security. Through all of the changes that we've seen in healthcare, this is still a number 1 area of concern for us. So you'll see a number of events posted this year talking about these 4 areas. And this is where we're focusing our attention this year. Next slide. We are a member-driven organization. This is all of the members who are a part of EHI. We're very proud of our members, and very proud to call them members. If you are interested in joining EHI, you can email wrong email address. It's info@ehidc.org. Sorry, it's been a long week. And if you'd like more information, please email us, continue to reach out. And we have a number of great options for our members and ways to engage and interact and be part of our thought leadership and our thought partnership conversations. Next slide, please. Coming up, we have a lot on the horizon. You will see there are a number of webinars coming up. We actually have one tomorrow talking about workforce burnout. This is going to be a really interesting one. And then on March 9th, we have our ever popular series, HIPAA for Dummies, as we sarcastically call it. Nobody's a dummy, but it's a very intro conversation to HIPAA. And on March 22nd, we're talking about interoperability, which has been a hot topic the past couple of years. Lots of changes, lots of policy rule changes. And then on March 29th, we're talking about AHL usability and optimization. Please go to our website. It's listed on the slide. Feel free to register. Everything is free. And they are all recorded. So if you do miss them, you can always go back and view the recording. And then we also have things that are members only. We have our work groups and some briefings. We do have a task force that is focused on our public health modernization. Our two speakers today are illustrious members of that task force. So I do want to say thank you in advance for joining us today. And then we also have monthly member policy briefings. Again, these are all member only events. If you'd like to join us as a member, and we'll continue to send information. Next slide. So as I said before, this is today's webinar is part of our education series on public health modernization. We actually have about 6 webinars in total that are planned, dealing with different issues of public health modernization. I believe on the next slide, I'll be able to, I think, can we go to the next slide? Yes. So these are the dates for our upcoming webinars. Today, there's the Learning from Pandemic, which you're attending. In March, we'll talk about privacy and security. April 5th, data and technology. April 21st, which is one of my favorites, improving health equity. On the 12th, we'll be talking about policy implications and future legislative needs. And then lastly, what does a modern public health system look like? Today's conversation really is going to lay the foundation for these 5 remaining events. And I encourage everyone to go to our website and sign up. Really great discussions, really great speakers lined up, and they're all free, all free. Next slide, please. So today we'll be talking about what the pandemic exposed and taught us about our public health system. Such a broad topic. Unfortunately, we only have an hour to talk about it, but I think it's a great place to start. In general, before you start looking in the future, you really have to look at the present and the past and really take an honest assessment and an inventory about what are the lessons that have been learned and how do we not repeat the same mistakes, and how do we ensure that, especially in the case of a pandemic, that we are in a more proactive stance as opposed to reactive. Some things are out of our hands, and I think that's something that we definitely learned. But hopefully by the end of today, we will all be at a place where we share ideas and we hear what's going on, and kind of hear what's happening in the industry. So next slide. With me today, our two speakers, as I mentioned, are from our Public Health Modernization Task Force. And again, I do want to say thank you. We have Richard Hornaday. He is the Director of Solutions Engagement for Allscripts, one of our members here. And then we also have David Horrocks. He's the President and CEO of CRISP. Big ups to Maryland. This is our HIE here. I'm from Maryland, so anytime I have an opportunity to talk to somebody from CRISP, I will take that opportunity. I do want to say again, thank you both for being here. Next slide. And so with that, I'm going to turn over to Richard, who's going to talk to us about what the pandemic exposed and what are the things that Allscripts is looking at. Richard?
Thank you. Thank you for the opportunity to come talk to you all today. Just as you can see from my affiliation here, I'm with Allscripts, and so I'm going to be bringing a bit of a vendor point of view on this, but if you go to the next slide, in reality, what I'm really trying to always bring to these types of discussions is a systems engineering view. And as a systems engineer, I always try to look at the big picture and then attempt to optimize across multiple, if not all, of the related subsystems. So when I'm looking at these things, even if they're political or regulatory type things, I look at them as all part of a system, and I'll talk a little bit more about that here in a second. And a lot of what I'm always trying to drive for these things is these 2 quotes down here from Benjamin Franklin. If you fail to plan, you are planning to fail, and the infamous an ounce of prevention is worth a pound of cure. Those are sort of what I consider to be the opening mantras of any good system engineer. You're always trying to optimize and look at these things. So all the discussions that I'll be introducing here, as well as any follow-on conversations, that's my bias coming into all of this. This is what I always look at these things. So if you can go to the next slide. So whenever you talk about a system, it's useful to identify what are the components of the system. And while this socio-technical model was something that at least I came across as part of my work on patient safety, I think it really applies across the board to all of healthcare IT and healthcare in general. The key thing to note here is that I know a lot of times people will look at one particular aspect of this and say, this is what we need to optimize. And in reality, what we really need to do is optimize all of these across all of the various different aspects. So again, from a vendor perspective, it'd be easy for me to say, I'm going to focus on the hardware and software, but that's not doing it justice. One of the things we have a lot of discussions in the public health space is the people involved in all of this and making sure that there's training for them. And then there's rules and regulations and internal rules and regulations, as well as other aspects like funding that are all in there. They all get encompassed in all of these items here. And it's absolutely essential that we take a look at all of these things when we consider optimizing across the system. So for those of you who haven't seen it before, I've got the reference down here, but it's a very useful way of looking at healthcare IT in particular going forward. If you could hit the next slide. So when we consider the public health IT infrastructure, what are we really talking about? So it's basically a system, again. Its subsystem, though, from the current public health IT infrastructure is really a patchwork of these purpose-built systems, each serving a single need. But these purpose-built systems were not designed to be part of an overall system. They really were sort of independent. And we talk about them as being silos, but it's more than just being silos. It's actually that they really weren't intended to. And so you can't necessarily fault them. They're doing exactly what they were designed to do. But the key thing is that in limited or in many cases, no formal requirements for these things ever to system interact. So you'll end up with one public health system that at the beginning doesn't look like it needs to interact with a second system. And whenever that interaction is identified, it's not really known very well or easy to move. And that's the next point down here, is that these systems were not designed to be extensible beyond that single purpose. We found a lot of this during the COVID activities where you'd sit there and say, well, I get a lot of this information, but I don't get all of it. And how do you pull all the various different sources together? And just even that simple correlation capability became a very, very challenging problem for us to be able to solve. The other thing I've noted down here is that going back to the idea that people and other aspects are part of that system, this purpose-built aspect is not really only with the system itself, but also with the staff who operate them. A lot of times what you'll find is that you'll talk to people about extending a system and they'll say, well, we don't work that way, or our people couldn't handle it that way. And so again, you could change the system, but you still need to be able to make sure that the people are trained. And that's going to be a key thing, I think, when we look going forward, is to be able to make sure that we aren't training folks for any of the systems that we may build for just that particular purpose, but really to be able to say we want them to be able to handle whatever may come down the path here. If you could go to the next slide, please. So the obvious question, how did we end up here? The easy answer is, well, it's complicated. And I've shown my little system picture down here, is, because it's very complicated. And the likely factors I've got down here, that last one I'll actually cover first, the fear of complexity. Again, to my bias as an engineer, complexity is not something to fear. Complexity is something to be managed. I think that's got to be the way we look at these things going forward. So with that as an overriding factor, funding is an obvious one that we've looked at before. It's very usually tied to this very specific item, like a specific disease condition or a specific activity like immunizations. And that then drives that purpose-built solution to just that specific task. And by the nature of all that, it's also inherently reactive. We tend to say there is a problem, we need a solution to fix it. The problem already exists, it's already festering a little bit. You take some time to be able to specify things. You take some, to be able to really define the issue and identify what you need to do with it. And ultimately that drives the development, and then that drives the implementation. So you also get these long lead times on these things, even though they're reactive. The other challenge that we often end up with is this fragmented regulatory and legal environment. And this is driving and requiring additional complexity. While the systems themselves are not designed for extensibility, anyone who's been working in this environment with public health systems knows that some level of extensibility or customization is just going to be a presumed requirement. And that's due to the extensive variation amongst the various different jurisdictions. So as a prime example, when we did electronic case reporting, I had to really talk people within my company to say, no, this is not going to be one of those things where we're going to have to customize it this way for this regulatory agency and this one for this particular public health agency. It really will be one interface. That's the intention here. We're going to go to one particular interface. And from a vendor perspective, being able to get them to actually scale back their thoughts on the complexity and the cost of doing this was an essential aspect, because they put in the additional pads for just knowing they're going to have to do all this customization. Again, we don't know what the customization is always going to be, but we know it's going to be there and we have to accommodate it. Okay, if you could go off to the next one. So what are the impacts of all this? Flexibility, time to market, the lack of the focus on the extensibility. It made existing systems too slow, too costly, more often than not both, to be useful for the emergent needs such as COVID. And we saw this a lot. These purpose-built systems, despite their limitations, they do drive large lead times. So that's it's sort of a double-edged, double whammy there. And the cost aspects of the impacts here. Even a simple system is known to likely incur these additional costs due to customizations, like I mentioned. And these are also often can be estimated to be equal to or larger than the cost of the base system. So imagine if you're coming to try to develop something and you say, well, it's going to cost me X to be able to develop it, but then I also need to allocate X to be able to do all the customizations. When you come into an environment where you have a lot of competing priorities, these costs with unclear benefit, they're very difficult to manage from the prioritization perspective of all that. So that's part of why we end up with some of these trade-off discussions that we have often in these environments. If you can go to the next slide. So when you look then at COVID, I often look at COVID as being the exposer of all weaknesses. It really did highlight across not only our industry, but so many places, all weaknesses that were in our system, in our environment, and our society in general. The fact that we had no generic infrastructure and that existing infrastructure being geared to purpose-built systems, it was difficult to provide the data that was requested. And in addition to all of that, the data that was needed was constantly evolving. So even if we were able to be rapidly advancing on these things, as we saw, especially in the beginning phases of COVID, you would collect data that would expose another issue, which would then identify another type of data that you need to have. So it was constantly evolving, and that flexibility and that expandability really needed to be built in, or else we really would have never been able to manage things. And that's the next point down here, is that these systems were not built for exploratory data capture. The necessary data capture is often hard to revert to. Often had to revert to the manual data capture, and we saw that with situations where, well, I have some of these information. It's going to be too complex to merge things together. So what I really need is for these hospitalists and the various different people in healthcare to be able to go off and start giving me spreadsheets and maybe even fax them. And that was an extensive impact on the resources within healthcare, and at a time when they were already overextended due to the clinical needs driven by COVID. So the bad situation made worse, basically. And then, like I mentioned, some of these things, by doing them on an ad hoc basis, well, they drove at transmission methods such as email or fax. And we didn't develop even common templates for data input for this, which meant that the governmental agencies and the public health agencies that were getting this data, they had to take a large amount of this COVID-specific information and collect and transpose that data. And that took a lot of added cost and complexity on the receiving side. So we were overly burdening the clinical healthcare side where this stuff is being generated, but then also overly burdening the receiving side. And from an engineering perspective, that is far from optimal. The other thing this does, though, is it also drives errors and contributed to delays in evolving our understanding of things. So a lot of what I've provided here, and this is always painful for somebody like me to come in and say, here's a lot of issues, but not get any particular solutions to all of it. So it's my hope and goal that through these discussions that we're going to have here today and the panel discussion, we'll actually start being able to start moving the ball a little bit on identifying solutions for all of these items.
Thank you. That was very eye-opening. It's so interesting as the question is, how do we get here? So simple, but it's complicated. It is very, very complicated. Many, many layers, many things to think about. And, you know, that's why they say hindsight is 2020, right? Because as you're looking back, people are like, oh yeah, we should have thought about that, you know, or oh yeah, it was really obvious. And as you've seen, it's not always obvious, especially when you're in a position where you're responding and everything is time critical, and there just isn't time to to adequately react in a way that, you know, the way that we would like to, especially as, you know, public health professionals and the systems and providers. So thank you for that. I imagine of our next speaker, David, that a lot of things talking about data, and as an HIE, I imagine that you have a really interesting perspective as well. David, I'd like to go ahead and turn it over to you to talk about exactly that. What has been CRISP's experiences pre and during COVID, and how are you able to like link that information? But I will let your presentation speak for itself, please.
Thank you. And I will describe some ways in which the HIE infrastructure proved, I think, very helpful to our partners in public health and to the delivery system. But I'll start by saying the infrastructures were not purpose-built for pandemic preparedness. There are some ways in which the investments that were made for other reasons ended up being valuable to us. But I'd love to say that we anticipated this. We didn't. One of the most boneheaded things, 3 days before the office went virtual for the next year, I signed a lease extension for 15 more people and 15 desks in the building. No one ever sat in those. I just didn't see it coming. We were not prepared for what came after. But in the end, we are very gratified to have been able to play a part. And there are really three things, if you flip to the next slide, that we've been able to do with an HIE infrastructure that I think are unique and helpful for public health infrastructure during this. And those three are listed here. And the first is that we are able to combine data sets in ways that enhance the data available to public health. And if you think about a very simple example, I know many HIEs assisted with this, and that is early in the pandemic, there was a question of whether there was disparate impact of COVID, and we didn't have great social factor data on the COVID case files that the states were collecting. In particular, they were missing race and ethnicity. And in Maryland, we were able to go from a not very high rate of race and ethnicity on that case file to over 80% very quickly, and then subsequently over 90% by combining that COVID case file with prior hospitalizations, with Medicaid claims, with some other encounter data where race and ethnicity had been captured. So you put those things together and you enhance your COVID case file as an example. And there'll be some other things I'll show where this identified data, which an HIE holds in trust, can be combined to enhance the data which is captured for public health purposes. Then the second thing that we've been able to use the HIE infrastructure to accomplish is to get information that's been collected by public health back out into the field where clinicians may take advantage of this. And during the pandemic, the very first thing you think is the fact that your own patient may have tested positive for COVID. You may not know that. An HIE already has those established patient relationships captured. If you combine that patient relationship with the COVID case file, again, you can then send the notifications that get a primary care doc involved. Perhaps if someone is hospitalized, that notify a primary care practice of that fact as well. There are other public health information that's been captured under authorities that exist for 100 years that we have not done a good job of communicating back, and I'll show a couple examples of that as well. And then the third thing that we've done, particularly in Maryland, I should have said this, that CRISP is the state designated health information exchange in the state of Maryland. We serve the entire state. We also work in partnership with 4 other state HIEs to share a technology stack. So in the district, in West Virginia, and then more recently in Connecticut and Alaska. And so in each of those states, well, the first 3 at least, we were able to partner with Public Health, with Secretary Schrader here in Maryland, Dr. Nesbitt in DC, and then also in West Virginia. But I think in Maryland, we had the most robust infrastructure. And the state turned to us as a force extender, if you will, for interoperability projects. And we are able, as a public-private partnership with not all of the same sort of overheads, if you will, of a state agency, and perhaps some access to technical talent that might be harder to employ within the state. There are projects that we could move more rapidly to accomplish. When the secretary decided that we would have testing at the vehicle emission sites, and he didn't want 2-mile lines of cars waiting to get tested. He wanted doctors to order tests. He called, and then in just a very short period of time, a week or so, we were able to stand up a physician ordering tool that fed into a scheduling tool, which allowed patients to then schedule a test at the vehicle emission site. This is back when tests were in short supply. I'm sure you can remember that. And it's a project that the state by itself would have taken a much longer period of time. But because they have this infrastructure partner who already has all the docs credentialed, and they already have usernames and passwords, and they know how to work with us, we were able to function as that kind of interoperability partner and a force extender. And then we did the same thing with immunization data and various reporting that happened from hospitals and from skilled nursing facilities. So just next slide, I'll note a few things about our organization that allowed us, I think, to serve this role effectively. The first is that we are statewide, and we sort of match the jurisdiction of our public health authority, which is also statewide. And we have this official sort of role in the state. We're designated to serve this purpose for the state. So it was a very natural thing for the secretary or for his team to call us and say, can you help with this? And they knew that we were going to be there to provide help. And then I said we hold this data, lots of data in stewardship, and we're able to do that in part because we are there's a lot of oversight. We are regulated. The community, it's a multi-stakeholder board, and we have patient advocates involved, and so we're held to this very high level of privacy protections, and that has allowed us to do something that perhaps we wouldn't all trust, say, the state government to hold all of these medical records and to only use them in certain ways. But this other community asset, I think, is a place that you can do that, and that proved to be, in my judgment, helpful with COVID. So I have a few more slides of examples of things that you can do. If you go to the next one, please. These are an example of combining data. You can combine school absentee data with pediatrician rosters, and then with appropriate family consent, you can communicate student attendance data to the pediatrician, and that was piloted in the district with the help of a number of stakeholder organizations. We're providing more situational awareness to public health than they would get just from reportable conditions. And I can tell you about one of our failures, though. We early in the pandemic got the call, said, David, we know about hospitalizations for COVID, but with very little testing, we're not clear whether there's a lot of respiratory illness in the community. Has there been an uptick based on visits to urgent care and primary care practices? And couldn't answer that. We couldn't answer that. I thought we should. We have so much of that connectivity, and we just weren't quite tooled to answer those questions. Well, we're shifting some of the resources so that we can answer those questions for our public health leaders. Here, the next to the bottom one, analyzing COVID breakthrough infections. This is a great example of combining data sets to enhance our understanding. If you want to understand whether vaccine efficacy, let's say, you have to combine your immunization registry with your COVID case file, just to first identify a breakthrough infection. But surely an outcome of interest is going to be hospitalizations. So you need the hospitalization data, which as the HIE, we do have that hospitalization data. You might want to know length of stay. Well, because we have the ADTs for the admission and the discharge, we can calculate length of stay. You might want to understand if certain chronic conditions leave one more susceptible to a breakthrough infection or a bad outcome. Well, we have chronic condition flags from claims. You've got mortality as an outcome that you'd like to understand, and the vital statistics data, which the state has, can be combined into that same data set. And then social factors, again, might be an important thing to understand as you evaluate the efficacy of a treatment or of a vaccine. And all of that can be put together and then sort of spit out as a limited data set for the community to understand. That last one there says communicating to a clinician. This is something public health knows. They know about previous overdoses as a reportable condition. How do you get that information to a prescribing clinician so that she knows a person's medical history and can make the best decisions on pain management, pain contracts, and the like? And then I have one more slide with a few other examples of things that you can do. This one at the top, I know our peers in California have been working to do this, understanding what's happened with preventative care during the course of the pandemic. Have there been changes in the rates at which preventative care is happening? And are you seeing disparities between neighborhoods and how preventative care is occurring? Well, again, you've got all the data. If you put it together appropriately, you can answer those questions and do it in near real time, not 2 years after the fact. Do it in a time frame when you actually can take some action to try and rectify problems. Have your behavioral health bed registry, which publishes real-time bed availability. That's something that we're working on, but just knowing about the number of ventilators available in each hospital is an example of one of those integrations projects that an infrastructure such as ours can be useful for. I have a few pictures on the next few slides. This first picture is of some random hospitals in Maryland. I won't say which ones, their ED volume during the course of the pandemic. And we are getting all this data via ADTs without putting any new burden on the hospitals to report. The next picture for an undetermined period of time is case numbers by zip code in a county in Maryland. And our public health officer, she would get this data and even more detailed if she wanted it, down to census block. And she can overlay, again, other data like age and certain social factor data to best understand what is going on in her county. She has the same information for vaccination, so she can see if there are pockets of the community where perhaps the vaccination rate is low and can really target her outreach efforts to try and drive a positive outcome there. Next graph is this is some random counties in Maryland. Again, I won't say which ones. It's just hospital admissions broken down by age. You can see that you could look at by race, ethnicity, or get a bit more granular on some of the other data. And the last thing, the last graph, this is fake data, lest anyone worry, is an example of a report that we've created for about 300 practices, I think, have used this in Maryland, and it's designed to allow a practice to very easily do the outreach they need to try and get their patients immunized. It shows the list of patients, their immunization status, and allows you to take notes for where you are in your outreach. Certainly practices that are part of a shared savings program are engaged in this activity. They have access to this data through the state's immunization registry directly, but it's a bit cumbersome. And when you go through the immunization registry, the registry doesn't have any way of knowing for sure whether the provider is looking up someone with whom he or she has an existing patient relationship. Well, we do have that data already in the HIE, and it allows for this sort of report. I know if a doctor has said, David, you're in charge of the outreach, she probably would want me to sort this thing by age, maybe flag some chronic conditions like diabetes or asthma, and say, start here, make sure you are outreach there first. And that's what these reports allow. Again, it's an example of combining data. What's exciting to me about the potential of these infrastructures is that we can do these things without putting any new burden on the delivery system or heavy duty reporting requirements. All the data exists electronically. It just needs to be put together in a way that makes it more useful and with appropriate patient privacy protections. I believe that this model can go a long way to improving public health infrastructures, not just as we deal with the ongoing COVID after effects. Let's hope that it's after effects, but also with other public health emergencies. We know that the number of overdoses with opioid use disorder are very high. In fact, some of the infrastructures that we leveraged for COVID were actually built for opioid abuse, evaluation of opioid abuse, and really targeting resources there. So I believe that we have so much data that can be useful for public health if we just put it together. Thank you.
Thank you. Thanks to both of you. You raised a lot of really interesting points. I was actually taking notes. I can't wait to dive into this. It's always great to hear from Chris because I'm a Marylander. I was looking for my zip code there on your slide. Didn't see it, so I know we're not on there. But I think it's really interesting, that Richard started with, this sort of there being competing priorities, and sometimes solutions can be a bit burdensome. And then David, you kind of talked about how through partnerships and leveraging resources through all this data, you've like reduced that burden, not eliminated 100%, but definitely reduced it. So like there is that availability, and it sounds like between the two of you, the common thread really is leveraging resources and working together, and knowing who already knows what, and who already has the information you need. I want to ask you, David, just it popped in my head. So like through everything that you've done, you talked about the different partnerships and all of this data, like what has been your biggest takeaway as you've worked with like public health agencies?
I am so impressed that we had many dedicated public servants who were working extremely long hours with really great intentions for the communities that they serve. So I know that as some of the particulars of public policy have been politicized, that that some folks, I guess, look askance at that. But boy, everyone with whom we worked, they were very dedicated and working super hard during this period. So that stands out to me.
That's great. Whichever the period, the beginning or the end, like where where are we in this? And so, Richard, I have a question for you. As you know, as we've talked about, as David talked about these partnerships and the sort of resources and how to kind of share this data. I just want to know from you, talked about the system being siloed right now. Like our system right now is very siloed. It's very standalone. It's not very flexible. Those are kind of the issues that we're having. But why do you think that it's absolutely important that we go from that siloed system to one where clinical and public health information are integrated and easily exchanged and are much more agile?
Yeah, and David touched on a lot of it in the sense of the data is already out there, and there's many systems that are out there, just not the ability to either access all the information, or even if we can access the information, to properly correlate the information together. David didn't go into the technical details as to what is behind all that, and there was a comment or a question in the activities here about patient identity and matching. Those are all key aspects of, well, I get a lot more information if I'm able to take information from one system and say it's related to this one over here. So that's how you can take situations and say, well, I know that this person who's undergoing this treatment here also had that treatment in another place over there. All of those things allow you to get that more longitudinal view of the patient. Ultimately, that's the goal of all these things. But when the systems don't even interact and things like that, even the situations of doing we're monitoring the information as it comes through, like an HIE will do, that provides a system solution for that particular region, but it's going to be a different system solution that's going to be over in California, as an example. They're going to do things a slightly different way. And so you don't necessarily always want to just rely on those activities that are sort of not coordinated to be able to manage that. So that's a key aspect of being able to say, rather than looking these things as piecemeal or happenstance as to how it's being done in particular regions, what's the overarching goals that we want to have here as a society and as a government? Because I'm sure the government's going to be driving a lot of the funding for this. What are their goals for this, and driving the requirements to ultimately help drive and achieve those goals?
Yeah, absolutely. And that actually brings up another question about sort of these fragmented regulatory systems and policies. They're at so many different levels. We have the federal level, and then we have like states, and then we have county and city, and there's so many, and I think we saw this through the pandemic. I think we're still kind of seeing it, where there was just such a, not only a fragmented response, but just fragmented abilities, and there was like competing priorities, right? And so I heard someone say a long time ago, part of why we're unable to be so nimble and our pandemic response and preparedness is a bit, is not as jointed as it should be, is because we have 50 different states doing 50 different things. And within those states, we have umpteen counties, umpteen cities. Is that something that you agree with? Like what's your take on that? Richard, David, both of you, I think, because you both have these high, these high levels. Is that a statement that you agree with?
Yeah, I'll start off on that. The regulatory requirements, like I mentioned a little bit earlier, getting them are an essential driver for consistency and ubiquitousness. Those are important aspects of things. But when you've got all the various different agencies, and we always talk about it's not 50, it's actually something more like 70 or something like that. When you get down all the various different public health agencies, there's really no way of being able to talk about consensus. What is the industry agreed set of information that needs to be done, or the industry agreed set of capabilities? So what you get is an idea that really no one's trying to even drive that level of consistency, which then gets you all this fragmented perspective on things.
David, what are your thoughts?
We are, a federalized system, and the public health authorities do exist in 50 different states and a handful of other territories and places. We aren't likely to, change that, but I'd love to see more model legislation and a bit more consistency approach between and among the states. As I said, we do serve these 5 jurisdictions, and sometimes the rules are a bit different. But that's one of the evaluations we've had to make when states have joined our affiliation is, are the policies consistent enough that we even could work together collaboratively?
And are they consistent enough? I guess the answer is no. So where should that drive really be? Where do you think it should come from?
And some of that also drives requirements for things like accessibility and access control. Just because one region says this information should be available and another region says no, it shouldn't be available, doesn't mean you shouldn't be capturing it consistently. You can do that in a ubiquitous way, in a consistent way, as long as you're able to sit there and say, for those regions where the information is accessible, they should be able to access it. When it's not accessible, you should be able to handle that with a general access control mechanism.
Yeah, I don't want to impugn anybody else's good work, but I would suggest that although it is at times painful to have different policy among the states, I don't believe that a federal approach to all of our public health reporting is necessarily the answer, or to have federal policy pushed down, or certainly not to have direct reporting from clinicians up to CDC. I worry that we would not have that data would make it up to the feds. Perhaps we'd have a better picture of what's going on nationwide. I worry it would not get its way down to the local health officer in Montgomery County, Maryland, or to the clinicians or who are the pop health people at a particular hospital who need to understand what's going on right locally within their community. So we do need to have a better picture of what's going on nationally, but I think a more pressing need is to have strength at the state and county level as we respond.
That's really interesting. You talked about more local. So my question to you, David, then is, how can public health systems collaborate with more of the community-based health-related organizations who would be easily overwhelmed by receiving all this data or having access, or not even so much the data, but with engaging with communities and maybe even like providing some of it, and could be overwhelmed a little bit. So where do you see that is collaboration? Do you see that as necessary? Is it, what are your thoughts about collaborating with community-based organizations?
Yeah, of course. And I even think again about what we've tried to do with Maryland, working with West Virginia and with DC through this. We've taken best practices and applied them in all 3 jurisdictions. We have some very talented folks who worked on the same problem essentially across those jurisdictions. So I think it is important that we take the expertise that we have and we do reuse that, because it is a lot to build a new data lake every time you've got a problem to solve. We do want reusability, and I think we see the beginnings of that in what's emerging through the pandemic response.
And following up on that, you mentioned the idea of these data lakes. I mean, in essence, that's a skill set that is evolving, and yet I'm not entirely sure that all of the community-based health organizations, or even a lot of the public health organizations, really have the data analytics and data mining capabilities and strengths that they would need to truly leverage all that stuff to the extent that they're doing it. Like, as an example, you had some really great reports there, but those are probably reports that you've canned for them, things that your user base is going to need to see. A lot of what we can't anticipate all of that, and really the intention for a lot of these data lakes is to make them generically accessible with access controls, obviously, to allow people to do whatever they need to do, so that when all of a sudden I need to start asking questions I wasn't asking before for something like COVID, the data's there, but they're also trained and are able to do the data analytics and data querying to get the information, and not having to rely on a single source to do all of that work for them, because that single source is going to be bandwidth limited then.
Yeah, I that's right, Richard. I'll point out that although we had some great data analysts, data scientists working on reports such as that. The partnership with our public health leaders, with Dr. David Blythe, our lead epidemiologist in Maryland, with his team, sort of telling us what they needed in these reports and helping us craft those was really key. It's the technologists by themselves aren't going to get it right, and the public health folks need, I think, the technologists' help as well.
Yeah, it's very much the case.
Absolutely. So where do you think our focus should be? Are we ready to move away from pandemic preparedness and kind of focus on pandemic response, or are we still kind of figuring them both out? Or is this, I'm curious, where do you think, where are we in this whole process of trying to improve, our public health system with pandemics?
Good question. So what comes next is hard
to
predict. And I already told you how badly I predicted what was coming. Just a few days before COVID hit hard. And I think sort of human nature is such that we're not always good at predicting. I remember reading in the book The Big Short that Michael Lewis, I think, about some of the guys who made a lot of money on the housing crash, and they concluded that that people don't process big but infrequent risks very well, and so that was part of their investment strategy, was to take positions that counted on something very rare but dramatic happening, and that's what COVID has been for public health. And we, obviously, most of us did not process that well in advance. So
and I think I think we've got a once in a generation opportunity here where it's unfortunate, but our society and people in general tend to say it's not an issue until it becomes an issue. And COVID really highlighted that it really is an issue. And that's given us the opportunity to take a look at things and say, well, what do we need to evolve and what do we need to recreate? And so for those that we need to evolve them with a common methodology. For those that we need to recreate, definitely presume that it's a fool's errand to ever try to presume that you will know what's going to happen before it happens. I know I sound a little bit like a broken record on this, but that flexibility and adaptability is really the key thing. It's not the only driver of all this, but if you really want to be able to manage everything that's coming off there, if you don't build that in as a day one requirement, you aren't going to get that. You basically get what you pay for in that situation.
I think that's really important, actually. And as I said before, hindsight is 20/20. So when you talk about, excuse me, flexibility and agility, it seems so simple. We all know that, this is what we should be doing. And I'm personally curious to see what we're going to do with all these lessons that we've learned. And I want to know if we actually learned any lessons, what are we going to do with these lessons that we've learned, in terms of like the gaps in public health and the impacts where we were all shocked by, disparities in healthcare, and that was very shocking I think to everyone, not just to public health and not just to healthcare systems, but I think to communities at large, So my question then would be, how do we continue to learn and change our systems and processes in a way that continues to make healthcare more equitable? I think a lot of times when we talk about this, we talk about it in the context of COVID, and COVID may be forever or may not. I mean, we don't know, right? And my personal concern is that we're just always going to frame it in terms of COVID, and then we're going to forget. The brain is very short, and we easily forget. So what advice do you have, either one of you, to how do we change these systems and our processes in the future to make sure that healthcare remains equitable and that we do actually take these lessons learned, internalize them, and actually make change, actionable steps that creates change? Like, how do you think we should do that? How do we do that? Where do we go from here?
Yeah, well, health equity is obviously a very big, challenging thing to address, but you do want, I think a starting point is just to be able to measure where you are. Was it Jack Welch who said you can't manage what you can't measure, or at least I was
what gets
thinking
measured gets done, something along, yeah.
when I hear that. And
Mhm.
we don't necessarily measure health outcomes, at least not in real time.
Mhm.
I'll tell you one of the things we're working to do right now in Maryland right now with the Department of Health, the antivirals, which will soon be available in greater supply. They require a primary care provider or someone to make a prescription, require an individual to get to perhaps a retail pharmacy to receive the pills, and we should be concerned that there will be disparities in how those treatments get rolled out. And if you can't say in near real time, let's say compare your COVID case file with the dispense data for those COVID antivirals to understand what percentage of patients over the age of 60 or whatever the right number is, or what percentage of patients with certain risk factors are receiving these and after what duration of time. If you can't measure that, how are you going to improve it?
Mhm.
So I think about that as something I believe an area where we can help in just the measuring on the front end.
Yeah, and if you look at that, there's really two components to all this. There's changing behavior and changing awareness. And while there may not always be a lot we can do about changing behavior other than increasing awareness, there is a lot we can do with increasing awareness. And you mentioned it before, David, about this idea of, well, I may not have race and ethnicity data as an example as one of these key differentiators we wanted to know with the feed X that I'm looking at, but I can correlate that feed with another feed and all of a sudden be able to tell you, hey, I didn't get information about COVID for this person's race and ethnicity, but I did get something about the race and ethnicity over here. So when you start looking at this as a truly longitudinal view of the patient, and being able to correlate information from multiple sources, as long as you say that's a key requirement for any system we're going to do here. We're not going to expect that every feed is going to have every piece of information that we're going to do, but we are going to presume that we will have sufficient information to do that. But part of that also then boils down to what is the right source of truth for that information. Any demographic information is subject to change. Even aspects of something like race and ethnicity and gender and all those things can change for, because they do different code sets or just because people change. Those things are important, and identifying what are the key sources of truth for that, not trying to make every single point in the healthcare environment the source of truth for those things is going to be key. Because then you overly burden the systems that maybe aren't really prepared to capture that information because they don't need to. They know there's other places that are more appropriate for capturing those information that's going to end up being able to tie that information together for anybody who's trying to drive awareness.
Yeah, really great point. Driving the behavior and driving awareness. I think that's definitely key internally and externally. There definitely has to be change all around. So we have 4 minutes left. I have one last question for the both of you, and that is, what's the role for technology and external partners for the future of public health? Richard, do you want to start?
Sure. I'll refer back to my socio-technical framework. It's just a key component, but it's not the only component. It needs to be the enabler, but ultimately scientific endeavors such as data analytics, et cetera, are going to be the key thing here. As long as technology can be the enabler for what people can do, that's where the change is going to come ultimately.
Yeah, I love the word enabler. I agree with you, Richard. It's a support. It's perhaps necessary but not sufficient to actually make real change. We're supporting public health professionals, clinicians, and others who do, I think, the heavy lifting in the field.
And my father was also an engineer, and he always would talk about the difference between data and information. You can have a data lake, but it takes somebody, a person, to go and make that data into useful information. So the technology can help you create that data lake. You've got to have the processes and procedures, the people to be able to make it useful.
I think that's a perfect ending. We'll say thank you to your dad for that drop the mic quote. Well, I do want to thank both of you. I think it's been a really, really interesting conversation today, and you've really kicked off our series in a great way. We talked about data, we've talked about partnerships, and we've talked about change, who the drivers of change. We've talked about some of the technology, the different models and things to think about, and how to really be prepared, and how to be more forward thinking, and looking at the lessons that we've learned and lessons that we're still learning, lessons that I'm sure the both of you are continuing to learn and putting your work every day. So again, I do want to say thank you for joining us today. And I also want to say thank you to the audience for joining our webinar as well. I hope that it was as informative for you as it was for me. I really enjoyed speaking to these two gentlemen. I learned so much. And I do want to remind you that this is the first of many webinars we have in our Public Health Modernization series. Sorry, these are the upcoming dates. Make sure you go to ehiadc.org/events to register. And I look forward to seeing everyone, or at least one of you, at our future webinars. Today's webinar is recorded, so if you were trying to take notes, don't worry, we will send you the link to we'll send you a link to the recording so that you can view it on your own time, on demand. And if you'd like more information, you can email info@ehidc.org if you have questions for either of our speakers, and we'll make sure that we forward them. With that, I want to say again, thank you for joining us. Thank you to the speakers, and everyone have a wonderful afternoon. Thank you. Bye.
Well,